Dr. Sri Ganesh for including me in this IC, and as you all know, Dr. Ritika has really pointed out that the technology is coming and all control will be the reproductive surgery procedure. It is having some safety and other things which I will discuss, and the next course will also specify, and then you will understand why the control is more important for LASIK procedures. I don't have any financial interest into the products I am using. We were doing LASIK and we were very happy with the examiner and microbiome. But before that, there was an ALK was a procedure which was developed by the George Barclas, which utilized the microbiome for both flap cut and the reflective cut, in which the flap was created and reflected on a hinge, and second pass of the keratome was used to calibrate and remove the lenticule of a desired size. But it was not having very high accuracy, and that is why the procedure was not very popular. And when examiner came, the accuracy of the examiner made it much more popular as well as more predictive also. An examiner has undergone a tremendous improvement, achieving very high effective accuracy in terms of ablation depth, profile system, depth control, and shape, and sculpting is the biorespiratory by which we remove the number. The compression laser system has shown to achieve a higher flap thickness reproducibility as well as better flap thickness uniformly than mechanical keratomes. And because of this, people are thinking, and the science is growing and evolving, and why not use the femto for keratoconiosis to do all procedure and avoid using examination. Carlsbad has developed system Vizumex, which has shown how it is effective. It is having a precision and accuracy for ablation at a various depth, enable all in procedure by femto to be done. And there is an aim right now, initially was to do a duplication of a LASIK, in which we were creating a flap and then the lenticule was restricted. When it was done successfully, we thought of that why to lift the flap and why can't we do it inside, and that is how the flap has gone into a smile, which will come in the next talks. The basic procedure is basically we are just showing the animation how the flap is being created. This is the cornea, then come to ablation, lifting the flap, remove the lenticule, and then reposition of the flap. And these are the steps how the lenticule is being created, anterior and posterior, two kinds of ablation done by femto, and this is the cornea which looks pretty normal, like the cell. I'm just going to show the animation video, which you can understand the procedure much better, and then we will show the actual surgery. This is the posterior surface of. There are two things, anterior and posterior surfaces, and the two surfaces, anterior and posterior, are created for any kind of number. So the time used by the procedure remains the same. And this is the basic advantage, and another advantage being the solid state laser. The femto is not affected by many factors, which will come later. And this you can see, the cornea is going to be used, and you can lift the flap, and the inside lenticule can be removed. This is of precise size. In ALK, astigmatism could not be calculated. Now with flaps or with the femto laser, astigmatism is also addressed. This is a long video, but this is the actual procedure time also. We are looking the eye. There are two microscopes in the machine. One microscope is for surgical resection and one microscope is for delivery of the compression laser. There is an infrared camera also by which you can check the centration of the pupil. And this is how from periphery inside it is coming for the posterior surface of the lenticule formation. Then it will have a side cut to create the side cut of the lenticules. And then we will start from the center to periphery for making the anterior surface. And this will pass over beyond the posterior surface. So it will have a kind of flap formation. This flap formation can be reduced to a very small size, just 0.5 mm to 0.75 mm, bigger than actual optical zone. And there is no transition zone in the femto procedures. And now we are going to shift it to the surgical microscope. And under the surgical microscope, because of this low energy and high frequency, you are not getting too much of the bubble, and the resistance is also very low. We are breaking the tissue bridges to create a flap. As you see in the previous video also, the flap can be lifted, and we are just doing a blunt dissection to break the tissue bridges, and this is how the flap can be lifted. And once the flap is lifted, we are going to dissect out the lenticule inside. This is pretty like a LASIK, but the flap quality is better than microbiome. You all know that femto is giving much more better flaps. They are equal thickness all around. Then the planar flaps does not induce much of the abrasion, and there is the basic beauty of the femto. And this is how we are going to dissect the leg tissue. And once majority part is dissected out, you can actually peel it off by holding it with the forceps. It does not break in between, so no fear. The only issue with the femto is that the calibration of energy is not that much sensitive with the examiner, but sometimes if the energy is very low or very high, then the tissue dissection is slightly problematic. But majority of the time, once the machine is set for days together, it does not require any calibration in between. And this is how the lentitude can be removed. Whether you remove -1, -5, -10, it is the same time for the surgery. In examiner ablation, when you do ablation, if you are doing more number correction, then you require to do ablation for a longer time, and that is having the effect of hydration, and it is not there with the femtosecond laser. This is how the laser is complete. When we thought of that, we can do it this way, then why to make flap? And my laser speaker will speak on the Ismail procedure, which is without flap. I am just showing a slight advancement in the flash procedure. We are doing the same kind of ablation, but when we are doing dissection, it is slightly different. The dissection is not being done to lift the flap, though the cut is there, but we are just trying to lift it from the small opening. This is not a very small opening because it was in the initial phase, and the company required that before you shift from actually flaps to Ismail, you need to do some procedure like this, so you actually understand where the problem can happen, and if problem happens, you can solve it then and there. And this is how the lentitude is removed. Though the cut was there in the periphery, but we have not lifted it up the back. The results are very good. We have not done large volume, but whatever we have done, they are almost pretty similar to the LASIK. Patients are happy. There are no much of a problem. The only issue is that the initial wow factor, as happens with the micronode of LASIK, it is not there. Initially, for a few days, the patient says my injury is not very clearly, but after 3 to 6 months, patient all becomes very happy. And effective correction is precisely controlled. And the basic thing is that stability is very high over the time, and the topographically also you can see there are potential advantages of the flex which we have understood. As the tissue removal is determined by the creation of femtosecond interfaces, many potential errors traditionally associated with exam laser ablation are avoided, including atmospheric conditions which affect like humidity and temperature, laser ablation rate due to the stomal hydration before and during ablation. Possibly inter-individual variation will also not be there with the femto, not much known because we have done very few number. Beam perpendicularity and variation in the surgeon techniques is not affecting the procedure. It is a one-time procedure. Once docking is done, this is all automatic. The reduction associated with lenticular cut by a femtosecond laser gives the potential for the procedure to be more accurate. The another advantage of flex procedure is that the flap diameter is inherently linked to the optical zone diameter of the tissue dissection. Suppose you choose the optical zone of 6.5, the flap diameter will be 7, 7.2, 7.3, whatever you want, but once you are comfortable, you just want to give 0.5 to 0.7 millimeter bigger than the optical zone. This will have a high impact on the biomechanics of the cornea because you are not cutting in the undesired place. What we were cutting in the microdome was usually 8.5 or 9 millimeter flaps, so we are not cutting in the far periphery. In flex procedure, the diameter can be reduced, that I have already spoken. That despite these advantages, there are still some biological variables which will require intensive research, and development of 100% accuracy is required. It is not accurate, but still it is a short-term study in which it will have some impact we have to understand. Most probably the major difference between the lenticular cut and accuracy by femtosecond delineation or exam ablation is elimination of tissues related to the exam laser beam fluence change. Like it happens with the change in angle of incidence of the condenser phase, which is not there with the femtosecond laser. The well-known cause of spherical ablation in LASIK was this thing, and because of this, there was a lot many patients not very happy, but now with femtos, this is not the common complaint. The night glare is reduced. The femtosecond, in summary, femtosecond lenticular delineation procedure offer advantage over LASIK, particularly with respect to the reducing the intention of high order abrasions lessening the biomechanical impact as well as the practical advantage for surgical techniques and laser maintenance. Whereas the previous attempts to perform intrastromal corneal ablations, refractive surgery yielded poor accuracy, maybe because of the not proper energy was used and the frequency was also not there. When we started, it was a 200 kilohertz machine, now it is a 500 kilohertz machine, and we were using a rate of the delivery was smaller, frequency was less, now we are having higher frequency and energy is reduced and spot size is slightly increased. With this we are getting better tissue resection. One more. The future is mine. Thank you very much.